Hello, everyone. A very warm welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. I'd like to begin by acknowledging the Ngunnawal and Ngambri people who are the traditional owners of the land where ANU is located and where we are broadcasting to you today from. And I pay my respects to their elders past and present. Many of you are joining from various parts of Australia, India, and the globe. And I would also like to acknowledge the traditional owners of all those lands and pay my respects to their elders past and present. I am Devishi, a medical student and a volunteer for the ANU COVID-19 peer support program. In joining me are my colleagues, Dr. Deepthi Talaulekar, who is a clinical hematologist and the program lead for the ANU COVID-19 peer support program, and Dr. Pinky Dharmshaktu, who is the Associate Medical Director at Merck Healthcare and also a volunteer with this program. Now, before I begin to introduce our speakers and panelists for today, a couple of quick housekeeping notes. All attendees have their videos and microphones switched off. This helps us keep the sound quality clear and reduce any interference during the webinar. I encourage all the attendees to ask questions, and to do so, please use the Q&A button that you can see towards the bottom of your screen. If you do not wish to be identified, you can submit your questions anonymously, and you can submit your questions at any time. The panelists and the speaker will go through them at the end of the talk. With the polls, there will be some questions that will pop up on your screen during the talk. Please do select your preferred responses to those questions. We can assure you that all responses will be anonymous. And lastly, if you have any technical issues or any questions after the talk, please email international.health@anu.edu.au, and we will try to assist you as best as we can. Please note that this forum is being recorded. So today's webinar will be delivered by Dr. Nicola Schembri on chest imaging findings in COVID-19 pneumonitis, where she will be sharing her first-hand experience of diagnosing numerous UK-based COVID-19 pneumonitis cases on chest CT, and she will discuss the typical acute image findings, early and long-term chest complications of COVID-19 infection. This will be followed by a panel discussion with our panelists, whom I will shortly introduce. And they will discuss more practical issues and also answer any questions from the audience. Dr. Nicola is currently on a fixed-term clinical placement as a specialist radiologist in Southland Hospital in Invercargill in New Zealand. And she has held a leading role in medical education, both in medical student and radiology specialist registrar training programs in the UK and Australia. I would also like to welcome our esteemed panelists, Dr. Raju Kalidindi, who is the CEO and Medical Director of Apollo Radiology International in India. And we also have Dr. Thiru Sudarshan, who is the consultant radiologist based at Nine Wells Hospital and Medical School in Dundee, Scotland. It is our great pleasure to have you all here. With this, let's begin the webinar itself.
Thank you. Thank you for that introduction, and thanks everyone for joining us this evening and daytime, wherever you are in the world. So this is just going to be my first-hand experience of COVID imaging with regards to the chest complications. We know that through various webinars that have been discussed already, COVID does affect other parts of the body, but for the scope of this session, we're looking at the chest findings. So yeah, we can move on to the next slide, thanks. So the background to all this is that at the start of the pandemic last year, there was this questionable role of imaging as to whether it is just going to be contributing to the diagnostic findings of what COVID looks like, but actually took on a more central role in the diagnosis of COVID when resources started lacking. So for example, in China, where volumes were really quite large, there was a situation where the resources weren't coping with testing. So it was found to be quite a useful resource to use CT scan as being quite a sensitive diagnostic tool in diagnosing the condition. However, across the rest of the world, there were some reservations as to whether imaging should be used as a first-line diagnostic tool, where testing with COVID PCR was actually still yet available in other countries. Now, in April, as the condition started spreading across the world, we needed to have a form of consensus across different imaging departments in different parts of the world. And Fleischner Society, which is based in America, came up with a consensus statement based on a scoring system on what we should be reporting and how we should be reporting these findings, with a view to giving an idea to clinicians on the degree of severity of illness, but also giving us a form of guidelines as to who should be imaged and not. Should we be imaging the whole population with symptoms of COVID, or should we simply be imaging patients who are symptomatically unwell that are requiring hospital admission? With my resources being provided to the UK market, there was the British Thoracic Society of Thoracic Imaging, which had its own guidelines put in place. The idea was on the same lines as that of the Fleischner Society, but the scoring system was slightly different, and we'll discuss that in the next few slides when it comes to the scoring of disease severity. Following on from that, then, we started seeing, as the pandemic spread and the condition started becoming more debilitating, we were seeing the outcomes of the condition with its complications. So a new population of diseases was emerging with regards to the long-term complications of these respiratory illnesses, which we will be discussing that. So the British Society then came up with its own follow-up guidelines on how we should be following up these respiratory ailed patients. Move on to the next slide, thanks. So the role of imaging was actually changing here. So from the questions as to whether this should be a diagnostic tool, it then moved on to being for follow-up. But we're also seeing that there were lots of challenges involved if we were to use this as a diagnostic tool to see if patients indeed were suffering from COVID or not. We were seeing in our departments, and this is something that I won't be delving too much because it's very much a topic in its own right, is to devise protocols on how we were actually bringing these patients to the department to minimize the risk of the staff who are actually taking those pictures and handling those patients from the wards and from the emergency department to the scanning department and taking them back to the wards, with the risk of spreading infection to our staff. So we needed to devise pathways to reduce that risk. The cleansing of the scanner was also significant impact on the throughput of patients coming to the department. So it takes a minimum of 30 minutes between patients from one scan to the other. And in 30 minutes on a normal daytime, we can fit in at least about 6 or 8 scans, depending what type of scan is being done, you know, with the idea that a CT brain, it can be done in about 30 seconds, to a chest abdo-pelvis being done in about 5-6 minutes. You can imagine, you can calculate the maths on how many scans we are clearly not doing in that 30 minutes of cleansing. So the logistics there had to be taken into consideration. The prioritization was also being focused on patients who were in the hospital, and also then patients who were what regarded as elective work, you know, so people coming in for routine work or oncology follow-up had to be delayed and postponed to an unforeseeable return to norm, whenever norm it was ever going to be, knowing full well that we're going to have a huge backlog, and the backlog is in the millions at the moment in the UK, which I can quote. And we saw that coming, and we're trying to cope with that now, which is really difficult. The other worrying thing, if we were going to be considering imaging as a diagnostic tool in the early stage, we full know now that, well, even at the time, we were seeing that imaging findings were not emerging at least until about day 6 of having had the infection. So it wasn't actually a very reliable tool at the very early stage, because we were getting this false reassurance that patients were actually negative when they were still positive all the way. It's just imaging wasn't depicting that at that stage. So then the consensus had to narrow all this down, basically, that the role of imaging was very much in the context of making a decision, management decision onto which patients we were going to triage depending on the severity of illness. And really then what actually emerged really quite importantly is to deal with the complications. And we will be talking about the complications in the next few slides. The other thing is that, as many of you know who are listening to this, the symptoms of COVID are very non-specific. There's very much cough and shortness of breath. And you can get cough and shortness of breath with several other illnesses that are not even necessarily an infection. And the role of imaging comes into play to exclude those conditions or separate them out if we're thinking of COVID-19 infection, because the management is going to be completely different. So I'll present you with the first poll question here. And for those of you in the audience who can look at these. So there are a few things that we can see on a chest CT, and there's a whole list out there that we could choose from. So which one of the list do you think is the most classic for COVID-19 infection? I'm just saying most classic. So yes, so it wasn't meant to be a trick question, obviously here. It's just really to just get going with the findings. So yeah, so in the acute situation, this is the commonest classic presentation that we see on CT. So this is a coronal view of the chest, and you can see this peripheral haze on the side. So COVID-19 infection tends to affect the peripheral of the lungs, tends to spare the central areas, unlike some other infections where the lung is affected quite diffusely. You tend to get more of a ground glass predominance rather than dense consolidation, unlike some of the bacterial lobar pneumonias, for example. There tends to be a lower lobe predominance in the early stage, but as disease progresses, as you can see in this particular image, the infection really starts to involve even the mid and upper zones. So it kind of ascends in that way. And then actually you end up getting more involvement of both lungs. It is quite common to have bilateral involvement with multiple areas. It's very rarely that we were seeing just the one lesion. In fact, the severity scoring had started by including just one area of ground glass, but I must admit, I don't think I ever saw a single case where it was just the one case. Now, there are some findings in the images that seem to be really quite sensitive towards COVID. They're still not specific, and we'll discuss this in the next few slides, but areas that are described as crazy paving, where you get inter and intralobular septal thickening, is something that was very commonly seen in the more severe cases. And then as severity progresses, there tends to be consolidation that develops around the pulmonary lobule. So they get this perilobular consolidation, which can also be referred to a reverse halo sign, because you get this kind of halo around the lobule. And then as the disease progresses and becomes more of something similar to acute lung injury in the context of very severe pulmonary injuries due to any other cause, be it due to trauma, be it other shock syndromes, peripheral consolidation then gets more evident in addition to the ground glass, where then we can see air bronchograms. But when that happens as well, you start thinking, and especially if the patient is taking a different trajectory, you start thinking, is the patient now having a secondary infection on top of this? So quite commonly, patients were getting bacterial infections on top of their viral infections. So sometimes when that happens, it's actually quite difficult to separate out the two. So these are some depicted examples of what I was referring to. So with crazy paving, as you can see in the left-hand side image, you can see this very fine, intricate of lines that are within the pulmonary lobules. You get intralobular septal thickening in addition to the interlobular septal thickening. And this is really quite a severe case. So these are examples of known positive, PCR positive patients for COVID infection. And as you can see then in the right-hand side image, with perilobular consolidation, you get areas of more focal consolidation, as you can see in the particularly there in the mid zone of your left lower lobe, where you get this area of spared lung, which is normal lung, and then this halo of consolidation around it. So the problem, like I was saying earlier, is that patients can present with cough and shortness of breath for several reasons, and the role of imaging here is really to help us separate these out. So going back to the initial poll question where I asked, what are the classic, which one of these is classic for COVID-19 infection? It is actually quite important to keep those at the back of our mind, because if the image findings do not quite fit in with what we expect for these findings, then we really ought to be starting to ask ourselves, are we dealing with another cause of cough and shortness of breath? And obviously, in this pandemic, people are still going to have the common diseases that we see on a day-to-day basis, like heart failure with findings of pulmonary edema. So for example, in the case here in the bottom right-hand corner, you can see an example of acute pulmonary edema where you've got a large heart. Fair enough, it's an AP projection, so hearts normally tend to look a bit big on an AP projection, but there's a lot of perihilar infiltrates there, which is not typical of COVID-19 infection at all. Like I was showing you earlier, the changes tend to be more peripheral, whereas in this case, they're more central. And also when you start seeing pleural effusions, you can see a meniscal line there. COVID-19 infection doesn't commonly show, doesn't usually be accompanied with pleural effusions. So if pleural effusions are present, in addition to other signs of what we think are classic of COVID-19 infection, start thinking of superadded conditions. So patients, particularly when we were seeing the first variants, they were very much affecting the elderly population. So in that cohort of patients, you are going to have underlying cardiac disease, and any infection is going to trigger a degree of heart failure. So you could have both conditions happening at the same time. So in this particular case, so in the image on the left bottom corner, you can see an area here of hollowness. So there's a cavity there, and COVID-19 infection does not cause cavitating lesions. It doesn't tend to form abscesses within the lung. So if you see an area of cavitation within the lung, you're going to be suspecting other conditions, other bacterial infections, or for example, tuberculosis. So particularly depending on where the ethnicity is of where this imaging is happening. So it would be nice then following this, we'll have discussions with our panelists, particularly Raju, who is currently in India, and see if there was any difficulty in separating these out during the peak of the pandemic. And then, for example, in the image in the top section here, we've got these areas of tree and bud opacification. Now, COVID-19 infection doesn't tend to cause areas of tree and bud. So when we see tree and bud, you're going to start thinking of other causes of small airways, inflammation and infection. So it kind of takes us away from the notion of COVID-19 infection, and again could bring in TB in the equation if this is an endemic place where TB is quite prevalent. So in fact, no, they aren't specific, and you're all quite right about that. The majority of people have answered to that, and I kind of gave away myself when I was talking about the crazy paving earlier. And yes, but this is really important to stress this point, that these findings aren't specific, and to be aware that we are still at an age where it's a situation where other conditions are still happening, and we will go through the COVID mimickers in the next few slides, because we could be denying patients of a specific treatment if we seem to be thinking it's one and not the other. And then we'll also then discuss the degree of severity with regards to prediction of comorbidity. And actually it tends to, so imaging tends to be a really good tool in the inpatient situation where we can triage and see who we are going to need to escalate treatment for. So these are the mimickers we tend to have. So let's see if I can annotate again without disrupting the session. So as you can see here, I don't know if you can see my pointer there. So with crazy paving, as we saw in the earlier image, now that was a COVID-19 proven PCR positive patient, whereas in this case it looks exactly the same. Fair enough, it's more extensive, but it's a condition which is rather rare. It's called alveolar proteinosis. So you have to put these in the context of the situation. So when we know that we are in a pandemic, it's unlikely that if we're seeing crazy paving, we're not going to be calling it alveolar proteinosis, because on the one hand, we know it is a very rare condition, and knowing that the prevalence of a condition which has similar findings is actually more common, then you're going to put that obviously on your top list of differentials, and obviously then it will be proven with the PCR test. But other conditions that are actually common, and we see them quite often, are, for example, in the left-hand side, right-hand side image, which is organizing pneumonia, and it looks very similar to COVID-19 infection when we see the perilobular consolidation, as you can see in these areas. And these patients are treated very differently, as in we normally give these patients steroids rather than any other management options. And you don't want to be denying a patient that. So obviously, if you see this and the PCR is negative, then you are going to be thinking of alternative diagnoses. Eosinophilic pneumonia is another one, as you can see, with that peripheral ground glass opacification. And in the setting of the pandemic, it's very easy to call that COVID-19 infection. But obviously, you have to take that in the context of what are the blood results. And if you've got a very high eosinophilic count, then it's unlikely that it's going to be COVID-19 infection, particularly if PCR is negative. For all I know, they could still have PCR positive and have other conditions going on at the same time. So it's really important to take everything into consideration. So with eosinophilic pneumonia, your eosinophilic count is really going to be high. So it's going to be very different in that case. So we can see if we can move on to the next slide now. So then with regards to severity, I'll show you in the next image how fast the disease can progress. Now, the images I am depicting are all from the Kent variant, and it was actually quite interesting to see that we had more patients. So from my experience of reporting via teleradiology for the UK, based in Australia, we were seeing a lot of the Kent cases being hospitalized, and many of these patients were rapidly progressing to very severe disease, needing ventilation and care within the intensive care unit. And the age groups were becoming even younger. So I'll be showing you some examples of patients as young as a 19-year-old needing ventilation and intubation. So the disease was having a slow start, but then the minute it hits severity, it quickly progresses to a very nasty acute lung injury. So the BSTI came up with a scoring system, which was actually broadly categorized into really just mild, moderate, and severe. And we found that as reporting radiologists actually quite helpful in putting together a reporting template, because we were using a template, and I'll talk about the templates later, to try and help categorize the severity of condition, which was aiding the clinicians to triage and see who might need escalation of treatment or not. And it was very much related to the number, at the start it was very much related to the number of areas of opacification that we were seeing. But as I mentioned earlier, it was very far in between that we saw less than 3 areas of ground glass opacification. More often than not, by the time they present to the hospital and are needing the CT scan, there were far more than 3. So I don't think I've reported a single case where I categorized the extent of disease as mild. They were all at least moderate, if not severe, by the time we got to scan them. And this is the next slide, we will show an idea of the progression of disease. So as you can see in the first right-hand corner image, so I'll get the arrow here. So in this particular case. So with the first case, as you can see, that was day 1 of presenting to the hospital with symptoms of cough and shortness of breath. And the initial chest x-ray was completely normal. So as mentioned earlier, you can have a normal chest x-ray for at least up to 6 days of having had the infection. But then disease really quite starts evolving, and it took about 9 days to get to a stage of, in this case, would be at least moderate to severe, because you have bilateral involvement, you have mid and lower zones, and you've got both sides being involved here. So you can see these areas of ground glass opacification in both lungs. In the peripheral, as you can see, the center is still very loosened. So you can see that there's sparing of the central parts of the lung. We don't have any pleural effusions. As you can see, the angles are nice and crisp. So that really eliminates any other causes such as heart failure. Heart failure, as we said as well, it will be more central and wouldn't be peripheral. So see the difference. It was 9 days to get to this stage of severity, but it only took 3 days for this patient to further develop areas of consolidation in addition to the ground glass. And as you can see from the tubes and lines of this patient, now they are in the ICU and they're intubated. So the rapidity of severity of the disease is really quite fast. And when we got to the stage of describing the extent, then clinicians could really make a decision based on the image findings on the escalation of care that was needed at that stage. So let's talk about the complications now. So as time was evolving, we could see that several complications were developing. We can move on to the next slide, please. Thank you. So these are a few of the complications. There are several others, but the commonest by far was pulmonary embolism. And in fact, based on the fact that we were seeing quite a lot of pulmonary embolism, this has been covered in a hematology webinar that has been discussed earlier in this series of webinars. But from our context of imaging, we had to change our imaging protocols such that the timing of the contrast given to patients had to be targeting the pulmonary trunk rather than the conventional CT chest, where it is actually scanned in a slightly later phase, which is an arterial phase, where the pulmonary trunk is not depicted as well. So most patients who were coming in as query COVID or looking for signs of COVID, we were automatically doing them as CT pulmonary angiograms to look at the pulmonary trunk and make sure that we're not missing a pulmonary embolism, even just at presentation. Adulterous respiratory distress syndrome is something that was developing pretty fast when patient severity escalated and they were needing to go into ICU for ventilation. And that is really when we started seeing very extensive involvement with consolidation and bacterial infection as a secondary. So many of these patients became very unwell and they were hospitalized. The hospital is already a place which is very prone for hospital-acquired pneumonias. And these patients were very susceptible to developing secondary bacterial infection. We were also seeing several cases where patients would develop spontaneous pneumothoraces or even just pneumomediastinum in its own right without a pneumothorax and with no signs or any history of trauma or any other cause for those air leaks to happen. So I'll show you a few examples of these in the next slide, please. So as you can see in the left-hand side, so I've done my own annotations because I wasn't so sure if we'd have the opportunity for annotations during the session. So in the far left image, you can see areas of secondary areas of consolidation. And this was the 19-year-old patient that I was very sad to see on my screens on one of my reporting days. And as you can see from, I'll use in annotation at this stage, because you can see that this patient is intubated, they're in the ICU, and you can see that there are areas of ground glass opacification and on both sides. The left lung is not as involved as the right lung, but this area of consolidation here is certainly very different to the rest of the extent of disease. And this was a patient who despite support, was needing more oxygen requirements, and then started getting really unwell. And he did end up having a secondary bacterial infection on top of his viral illness. On this image, it might actually be quite difficult to see because the windowing is done such that I'm hoping you can see part of the pulmonary arteries here on both sides. It's only a slice. It's always difficult if you can't see it in volume, I understand. But if you try and imagine, you can see a dark shadow there in an area where it's meant to be bright white. You can see large pulmonary emboli there occluding the main pulmonary arteries, and you can see the areas of ground glass opacification on both sides in this COVID positive patient. And then in the far right image, you can see that there is, in addition to the ground glass opacification that you can see in the background, there are these areas of kind of more fluffy opacification with tree and bud. And that again was another example of superimposed in bacterial infection on top of viral pneumonias. I don't have examples of the Pneumonitis, I must admit, but we were seeing, it wasn't that common, but we were seeing quite a few of those cases as well. So we can now move on to the complications chronically rather than in the acute setting. So, sorry, I can't remove that arrow there, but we can move on to the next slide. So the comments that we were starting to see is this fibrotic change in the underlying lung. So most acute infections don't normally tend to cause long-term damage in the lung. You know, I'm sure quite a few out here have had some form of bacterial infection at some point in our life in the chest. And whether it was viral, we didn't need to take antibiotics, but if it was bacterial, we took antibiotics, had the course, and we're back to our normal self. But the very sad thing that COVID is doing, and it is something that we did actually see with similar previous infections with SARS, for example, is that there's a fibrotic element that is affecting about 20% of patients who do get COVID-19 infection. And this is an example of a patient I had in my reporting list, where the first day of his scan, so I'm saying day N+0 because it wasn't quite the first day of his infection, but this was, you know, back on that day of the 2nd of December last year. You can see the peripheral ground glass opacification like you would see in classic COVID-19 infection, but only 14 days later, you start seeing these areas of traction bronchiectasis and the honeycombing that's developing, you know, these septal lines peripherally, in addition to in areas where there were the ground glass changes on the previous scan. And this is only 14 days apart. We very much commonly see fibrotic changes from other causes developing over a period of years, not within days. So this is the worrying thing about these patients, you know, and especially with particularly Kent, and also now with the Delta variant, we are seeing a large number of patients who are in the young category. So for these patients to end up with long-term lung conditions is actually going to be quite a big impact on the healthcare system with regards to follow-up long-term of these patients and the debilitation following this condition now. So we'll move on to the next slide, thank you. So moving forward, these are the things that we have to start taking into consideration. So we now are in a stage where elective imaging has obviously come back. So it had come back mid-end last year, but then had to stop again when Delta variant came into force. And there's this huge backlog. And only now are we start seeing the impact of this backlog, which already in a very strained resource of radiology reporting, particularly I can vouch that for the UK. I'm sure it's not too dissimilar across the rest of the world, and it will be nice to hear what one of our panelists from India will have to say on that, is that it's really going to become a really big problem to cope with the backlog. And obviously these patients who have been denied this follow-up, and obviously they have their conditions which we need to treat too. This debilitation of the chronic complications of COVID-19 infection and putting in resources in place to following them up long-term, both from an imaging imaging perspective, but also from the clinical perspective with rehabilitation and specialist clinic follow-up. We have to see how we're going to use our template. So we have been given by the societies, both the American and the British societies, templates for reporting. I did very much, since I was reporting for the UK market, we were using the British templates, and it was very useful in the British situation to have a standardized approach to the way we were reporting these findings for the clinicians to have a clear idea on what the next step would be from a management perspective. We could also see this trajectory long term with regards to research potential for this, and all our reports were being coded in our radiology imaging system. So we'd give a coding depending on severity, so that for future research, or even just as we're going, there's so much research going on as we speak, we could use these codes to bring up the images for reference. And throughout the UK and also internationally, there are these large imaging repositories for clinicians to refer to. And this is something that is all new to us. We're learning as we go. And it's really important for us to learn from each other and share our resources. You know, things like these webinars in particular, but particularly in the imaging perspective, it's really important for us to utilize these resources from these databases and contribute as well towards these databases for future learning. So we can move on to the next slide, thanks. So this is the example of the reporting template on the left-hand side. So you can see that it is very clearly defined with regards to normal findings, and then with regards to classic findings, and it gives you a really nice description of what we are expecting as radiologists to see under the classic heading. And then if anything doesn't quite fit in with that, could it be indeterminate, and it could be any other cause, or maybe still COVID in evolution, and then consider other findings that are not typical of what you'd expect of COVID-19 infection, and it makes you start considering alternative diagnoses. And these are the codes I was referring to. So we'd put that at the bottom of all our reports. So I'd put in, with this classic COVID-19 infection, I'd put in CVTC for classic findings. And there were similar codings for the chest radiographs. So it was a very similar scoring system that we would use for in our databases. This is another image repository that the BSTI was collating, and most of the British hospitals were contributing to this database, where there are hundreds and hundreds of images that we can look through for our learning purposes. So we can move on to the next slide, and I think really this brings me to the close of my presentation today. I really would like to acknowledge all the patients who have gone through this, and past, present, and future, because we are still in the pandemic. It's very much reached us here in the southern hemisphere. It's very much a reality among us now, and we need to be together to support each other through this. But I really want to acknowledge the consent of these patients in the teaching hospitals, who without the resource of their images to learn from, we wouldn't be talking here today and learning from each other's experiences and teaching ourselves for the future. And thanks everyone for listening to me today. We can move on to the final slide, and greetings from New Zealand. Thanks for listening.
Thanks, Nicola. That was quite an educational webinar, and I'm sure all the attendees who attended it today would have found it quite informative and educational. So now I would like to encourage all the attendees to submit their questions using the Q&A button at the bottom of your Zoom screen. And I would now like to invite our panelists, Dr. Raju and Dr. Thiru, to share their experiences and perspectives, and also answer the questions from our attendees. And I will hand it back to you, Dr. Nicola, to mediate the panel discussion and the questions.
I might just ask Dr. Thiru and Dr. Raju to perhaps tell us about their experiences in India while we are waiting for the questions to come up.
I'll take that question. Hi, everyone. My name is Raju Kalidindi. I'm a radiologist based in Hyderabad in India. And that was a great talk, Nikki. Thanks for that. And essentially, what I found is that the use of imaging in COVID has varied extensively across the globe, right? And depended primarily on the prevalence of disease at a particular time in a country and also the resources in that country. And when we looked at our experience in India, during the times when there was no major surge in cases, imaging was used as it should be. In cases where the diagnosis is in doubt, where we thought the RT-PCR was potentially false negative, and also to kind of grade the disease to triage ICU beds and things like that, which is the appropriate way to do it, and it fits in within the guidelines. But the moment the cases start going up, for example, in the second wave, everything starts getting overwhelmed. So first thing that will go out of supply is the RT-PCR capacity. And then we got to a stage where it took several days for the RT-PCR results to come back. So, and then CT by default has become the primary diagnostic modality for COVID. It had some benefits in that patients who were waiting for RT-PCR were able to get some kind of diagnostic answers from CT, and they were able to get some treatment. But there were also quite a few risks that came with it. And the first and foremost is that a normal CT was interpreted not by radiologists, but a lot of patients, some clinicians, as negative for COVID. And that resulted in these patients not quarantining themselves and potentially going around and infecting others. So that's something that we learned. And then we kind of had a discussion internally to make sure the language in the report clearly identifies that a negative CT just does not rule out COVID, and it just means that the lungs were not infected at that particular time in the course of the disease. So that's something we learned. And second thing is the grading of the disease. So in India, there is, for whatever the reason was, the CORAD scoring, which was a Dutch scoring system that was developed back in March 2020, when the pandemic was still beginning, was quite extensively used in India even during the peak of the pandemic. And that resulted in quite a few issues because the scoring was supposed to be a diagnostic predictive score. Instead, it was used as a severity score, and patients were triaged based on that. So I think the lessons that we learned are that it's quite important to have a nationwide consensus within the radiology community in countries like Australia, for example, that have not yet seen that major. Hopefully, it never will, but if it does, it helps to have an understanding amongst the radiology community and also amongst the pulmonologists and respiratory physicians as to what to use CT for, how do we report, and how those reports are interpreted both by doctors, the media, and the public. So that's what we learned.
Yeah, that's really good actually, Roger, and that's why I didn't cover on the CORADs in my session, because I really wanted you to bring out that experience of yours with CORADs, because with the BSDI scoring, it was actually quite helpful to keep it quite broad in those broad categories of mild and moderate and severe, and it seemed to work well. So I don't know if Sudarshan actually is around to tell us about how the scoring worked in Scotland, in Dundee, whether that had an impact, but I can't seem to see him yet.
I'm here.
There you are. Yeah, Sudarshan.
Yeah, the thing is, it's one of the many variables in COVID, right? From our experience, it's nice to have some sort of scoring, but the thing is, what you're scoring based on radiology and what the patient's status is completely different. Sometimes it correlates, many times it doesn't. So if somebody who you think, who's got mild severity on CT, whereas when you look at the patient's condition is really bad, and vice versa. So actually, I think basically we are still learning. We're still learning lots of new things, and I think there's always one of the things to keep in mind is just keep an open mind and learn new things. But I agree, we use the BSDI scoring as well, but it's at least it helps you when you're reporting, and especially when you're flooded with loads of cases, it helps you really to just come to a conclusion and sign it off. It's good in that way, but when you look at it from a clinical point of view, it helps most cases, but some cases it doesn't really. The risk quite a bit of variability between the severity based on CT and the patient's clinical severity. And we don't know what other variables are there.
Indeed. So following on from this, I'm going to the questions now that our attendees have kindly posted. And I'm going to start, I'm not quite going into the order they're coming in. I'm just going to bring them in depending on our discussion. And based on what you and Raju have just said about the scoring in relation to the patient's symptoms, there is one question here where it asks about how commonly are there abnormal findings on a CT done for other reasons? So for example, on the CT abdo and trauma, and are these patients often asymptomatic? So I'll put it to both of you. I kind of can add my bit then after that, because we were actually then scanning, particularly patients going to routine, acute surgery for abdominal pathology, for example. We ended up finding our situation having to scan their chest anyway as a screening for the anesthetist to see, and obviously those patients were completely asymptomatic of COVID. But how did you do it in Scotland and in India for these patients who didn't really quite come in with any symptoms?
Take this, actually, there's two bits to it. The first half, maybe during the first half of the first wave, we were asked to, actually it's the Royal College of Surgeons. They came up with a proposal that all patients who are going to theatre should have a CT chest perform for the anesthetist and the surgeon's benefit. We did this for some time, maybe a few months, and then it wasn't really productive, and then the guidelines were changed, and then they said it's no longer useful. But the thing is now, actually, in the second half, and at least during the second wave, what the hospital did was, so the emergency trauma, the emergency cases, they identified a separate theater for, we had amber, green, and a red pathway. So red pathway was for COVID positive patients. Amber was unknown, people who just turn off the street after accident or come with peri-perf. So they had a separate theater for them, and they had separate group of personnel, anesthetists, theater support staff, and surgeons. And the elective surgeries, what they did was they asked the patients to isolate for 14 days at home. The hospital even supplied their groceries, so they would have their test on the 10th day, and then a PCR test on the 10th day. And then on the day of coming and getting admitted to the hospital for surgery. And they had a separate set of wards, so it was completely different, right from the hospital entrance to the wards and the theaters. So that was during the second wave when we learned a few things.
Okay, so you didn't end up scanning those chests then? They just went for surgery?
No.
Okay.
Actually, the scanning the chest was maybe in the first, March, April, May 2020, and then it stopped.
Was that similar in India, Raju, or did you do things differently?
We didn't specifically scan the chest when we didn't need to, but obviously when we include the lung bases for abdominal scanning, or even for MRI for spine, we did find quite a few patients who were asymptomatic from a lung perspective, but still had COVID findings. So I think it again depends on where you are in your up and down curves. During the peak of a wave, a lot of asymptomatic patients that have any imaging of any kind will end up having chest findings. So so we did find quite a few asymptomatic patients with chest findings.
Yeah, no, that's interesting. And then, for example, so now leading on from that, there's a question which says, if RT-PCR is negative, would imaging be recommended if patients have symptoms of what we think is COVID? What have you done with those patients?
Yeah, I think the guidelines say that if you got 2 RT-PCRs negative, then you go on and do some kind of imaging. So chest X-ray in most cases, but CT in some cases is supposed to be what the guidelines say. But I found that threshold for CT, at least in India, was quite low. So even if the first RT-PCR was negative, the clinician is strongly suspecting COVID, they would get a CT straight away.
Okay. Yeah, it is very sensitive, and chest X-rays, like we all know, miss out a lot on, particularly knowing that this is a predominant ground glass presentation rather than consolidation, like some of the bacterial infections. It's very hard to see ground glass on a chest X-ray, and very subtle changes will not be visible at all on a chest X-ray, which is fair enough. So then a similar question from the same attendee, Manish. Is there a way you can differentiate viral infections? I mean, I struggle. I struggle to differentiate any inflammatory changes in the lung, and I do lung as my area. And, and I always find that is a real challenge when put under the spotlight by clinicians to try and ask me, oh, Nikki, what do you think the diagnosis is? And I'm like, it's a black and white picture. All I can see are shades of gray. And I can only base it on the symptoms you're trying to describe to me. Have you found it? Have you found a way of trying to differentiate these viral infections? Like, for example, so at the moment in New Zealand, I don't know if you're getting quite a prevalence of it in India or Scotland, but we're seeing a lot of RSV in our adult population. Now, RSV, to my knowledge, is very much a pediatric bronchiolitis and bronchitis, but we're seeing a lot of it in the adult population, and it's actually getting very close to what influenza would look like. But then it looks very different to COVID. COVID is actually quite nice in its own right. It's looking very different to most of the viral pneumonias I am accustomed with. But I don't know if you had a lot of overlap in India or in Scotland, where it was actually quite difficult to distinguish one from the other.
Yeah, I think
I'll take this. Actually, the thing is, I don't know whether it's due to the masking and the lockdowns. Actually, last winter, there wasn't much of influenza or any of these respiratory infections. It was mainly COVID. So whenever we see some inflammatory change, which looks like COVID, we say, no, that needs to be ruled out. Whereas we are in summer right now here, but this winter they're expecting lots of other respiratory infections to increase, because basically the immunity has worn out in people. So I think we are behind the curve on this, Nikki. So I think we'll see more this winter.
Yes. Yeah, I think so. Yeah, so it sounds like, from what I'm being told, we're in a similar situation in Australia where there wasn't much influenza because of the very strict hygiene that was going around. But yeah, for some reason, RSV has really picked up here in New Zealand, which is very unexpected. But we'll see. Now, there's a question coming up about the chronic complications. So there are two related to it with regards to, one, do the patients who do develop fibrotic changes end up having a poorer outcome? I haven't seen, it's still quite early for me to see these patients yet and see what the overall outcome is, but I don't know if you guys are seeing that now at this stage in the UK and India.
No, I agree. It's too early to make any conclusions on that. There is, as we all know, in a good number of patients, ongoing symptomatology that goes on for months. That includes breathlessness, that includes several other symptoms. So to what extent that is due to residual pulmonary fibrosis or whether it's just ongoing inflammation, it's I think, too early to say.
Yes, no, that's fair enough. And then following on that line of follow-up of chronic conditions, is should we be repeating these images for patients who are seen to have fibrotic changes? I mean, I know the BSDI now have given us some follow-up guidelines, but I understand it's very much guided by symptoms. But I don't know if you have now been seeing any requests being submitted for any follow-up imaging, or whether you're following any guidelines in relation to that.
Not really, Nikki. I think it's still early days. Again, we haven't really seen a correlation between the lung changes and the clinical picture of, you hear about these long COVID cases, but I don't think anybody has published anything regarding findings on CT with the clinical symptomatology. So I think it's still early days.
Yeah, no, I totally agree. Because I'm still reporting for the UK with these volumes, and I'm not seeing those yet. But having said that, we're in that double-edged sword situation where we are now into that backlog of elective follow-up imaging. So maybe we have quite a few of these patients who are stuck in that backlog, and we haven't quite seen them yet because they haven't had the opportunity to even get to the scanner because of these waiting lists. So there is a question specifically for the two of for Raju, really, in India. And the question is regarding, what kind of idea of volumes of cases have you been seeing during the second wave? It's difficult to put a number, I guess, isn't it, Raju?
No, I can say it per scanner. Scanners that were doing about 25 cases a day scan 120 to 130 a day. So it's about 5 or 6 times the usual volume. As I said, a lot of that, or at least some of that, could be due to inappropriate usage, but they had no choice. When there was no RT-PCR, CT became the default. But yes, the 5 to 6 times increase in volume of CTs is what we've seen.
And this will be COVID related or including everything else now?
Yeah, everything else has taken a backseat. There was very few patients coming in for anything other than acute emergencies. So 95% of those were all COVID scans.
Oh, wow. Okay, yes. Are scanners coping? Because I understand now in the UK situation, there was a calculation by the college that we don't even have enough scanners, let alone people to scan these people, as in, radiographers on site. They even click the buttons to catch up with the number. So, what are we going to do with the resource lag, which is a big issue now. So there is a specific question asked to me about reporting in New Zealand, actually. So is there a consensus here? So in New Zealand, we very much base this on the College of Australia and New Zealand. It's a combined college for Australia and New Zealand of radiologists. And most of the consensus statements have been taken based on the American framework. So I understand that if we were to go down that line, so we haven't seen, well, I'm right in the tip of the South Island, so I haven't quite seen, well, we have seen a case coming through from a ship that was out in the port and only got as far as getting a chest x-ray, but we didn't see the CT. But we don't have quite yet the consensus, but my understanding is that we will go down a line of consensus statement based on possibly the Fleischner, but we'll need to see updates from the college based on that to see if we will be disseminating this form of reporting. As you say, Raju, it can actually create more problems. So I'm trying to take a step back from going down the line of these formalized reporting patterns until we are actually faced with a situation where we're going to rely on that form of reporting from a prognostication and triaging perspective. So then there's another question for the panels. And so if COVID symptoms and imaging was mainly around, I'm sure it is the diffuse alveolar damage and vascular thrombosis, was there increased incidence of other vascular thrombosis or DVT? Oh, that's a hematologist question. So Dipti can answer that one. But I don't know if Raju and Sudarshan, you seem to want to answer that one.
Yeah, I'll take that. Actually, there is definitely increased incidence of thrombosis elsewhere in the body. Actually, we've seen strokes, abdominal, superior mesenteric artery thrombosis everywhere, wherever you can think of. So you really need to have an open mind, and if the patient is presenting in a different sort of way, you just need to, and again, venous sinus thrombosis, we still get referrals for venous sinus thrombosis, again, from people who had COVID and people who had COVID vaccination. That's another thing which is going on. But actually, there's loads of things. And if you speak to the vascular surgeons regarding the clot, they say that even the clot pattern is different. People or the interventional radiologists who do thrombectomies, they say the clot is different compared to the usual clot they see from atherosclerosis. They say this is more sticky and a bit more rubbery. They say what they say is it doesn't come back as one solid clot. You have to really work hard to retrieve it.
Well, that's quite a risk then, because the procedure then could be unsatisfactory with residual clot.
So it's very sticky, they say. It's difficult to take it out.
Oh, that's interesting.
So, yeah, I've seen quite a few strokes in young patients, and then we see lots of abdominal ischemia, superior mesenteric artery thrombosis.
Dipti, did you want to add anything to that? So Dipti is a hematologist and specialist.
No, not really. I think the only other comment I'll make is if you do see pulmonary embolism, I guess there's always the issue of where the clot's coming from. But once you've got a clot in one place, it doesn't really matter where it's coming from. So we, as clinicians, we tend not to try and chase that and get ultrasound Doppler for a leg clot, for example, in that situation. I don't really have any other comments beyond that.
So that's actually, you bring that up. So at the start of this, people were questioning that, so the concept, the physiology behind pulmonary embolism, like you alluded to, is that it is embolic from another source. But I think as research was coming through, it seems that it is developing de novo, and it's not actually embolic. So the thrombus is actually forming in the pulmonary trunks themselves, and there isn't actually a source that's shooting off these emboli, unlike the situation. And I'm actually not surprised by what Sudeshan is saying, that the interventionists are realizing that the consistency of this clot is very different to clots that the interventionists are seeing with atherosclerotic disease, and that would kind of support the idea of this de novo formation of clot, which is interesting. So following from that, then now there's a question regarding the post-COVID fibrosis, which says, are there any acute CT findings in the acute stage that could give us an indication that these patients might progress or will progress to fibrotic post-COVID lung? I don't know about Sudeshan and Raju. I found it difficult, I must admit. The cases I've seen where I've seen fibrotic change, particularly that example that I brought up with the fibrosis developing on day 14 from infection, there was no hint on the first scan, and the background lung, because I had a previous scan of that patient from previous years where he was completely healthy and had a scan done for other reasons. And the scan was completely normal. They weren't even smokers. There was no risk of any underlying lung pathology. But I don't know if you know of anything yourselves. I don't think there's enough literature out there yet to tell us if we can predict, but you can correct me if I'm wrong.
No, I agree, Nikki. I don't think there's anything definite, From my own experience, maybe there is an association with volume of disease, but that's my own experience. But I don't think there's anything definite.
Yeah, volume of disease, because I was thinking that as well when I was seeing really severe cases, and then they get their follow-up and it just disappears, because when I see severe cases, I'd say, oh, these are bound to get fibrotic change. They're so bad. They've gone all the way to ICU, intubated, all that. And then, 2 weeks down the line, their lungs are practically back to normal. And then somebody who didn't even quite get to that extent of severity develops such fibrotic lungs. So you could see that image I brought up, that patient never ended up having really severe condition. He just had the ground glass changes that you see in your moderate extent, never quite went down the line of consolidation in addition to all that. So I found it difficult. So Raju, I don't know if you had any different experiences to that.
No, I did not. And I think it's, I don't think it's clear who's going to get fibrosis and why. So I think we just want to wait and see.
Yeah, and I don't even know if it is variant related. So I was very much seeing it with the Kent. I haven't seen enough of the Delta variant yet. And I think as I kind of seem to suggest at the start, I don't think many of the Delta variants not as many are being hospitalized as we saw with Kent. So I clearly had larger numbers with the Kent. You have a lot of Delta in India, of course, and you're probably seeing a lot of the Delta variant, but I don't know if you've seen any difference in the fibrotic complications with Delta versus the Kent variant.
We haven't seen any difference in the pulmonary manifestations at all between the two, at least on the acute side. Chronic side, we'll have to wait and see. It's still too early for that.
Okay. Well, thank you very much, Bob. This has been a really interesting discussion. I don't know if there's anything, we don't have any more questions in the Q&A, but I don't know if there's anything else people want to add from the organizers as well.
Yeah, what I would say is if you're running an organization, you just need to be flexible. You know, these COVID cases go up and down numbers. So you just need to be flexible so that you can open up capacity as the cases rise. Maybe reduce your COVID capacity and open up the other normal capacity as cases go down. And we don't know when it's going to come back. And, you know, we're just keeping our fingers crossed for when the temperatures go down. So I think you just need to be flexible and as nimble as possible.
Yes, well, hopefully we won't be seeing those numbers here in the Southern Hemisphere, but it's a wait and see, I guess, isn't it?
I agree. Thank you so much, Nicola. I cannot see any more questions coming in. There's a thank you from one of the attendees, and I am sure that all our live attendees, as well as those who will be watching the recording post the webinar, will find this talk and the panel discussion quite educational and informative. So also thanks to the wonderful audience for joining it today, and Dr. Nicola for presenting, and Dr. Raju and Dr. Sudarshan for the excellent panel discussion. I will quickly wrap up this presentation. Okay, so there's a thank you. A quick note on the next webinar, which will be delivered by Dr. Satish, who will be talking about pediatric COVID and multi-system hyperinflammatory syndrome, MISC-C, in children. And this will be held on 25th August. Same time, so please go and register onto the website if you're interested. Now, I would launch a poll for the audience to rate the webinar because we really value your feedback. And if you'd like to provide any more subjective feedback, you can always email us, and I'll share the email address towards the end. And a final note on the ANU COVID-19 peer support program. If you are a medical or healthcare professional, you can register to volunteer using this website, and there's a form up there. Or if you'd like to seek support, you can also visit this link and fill in another form to contact us. You can also email us on international.health@anu.edu.au or WhatsApp us on the following number.